Hey, good afternoon, everybody. Welcome to our special office hours in December. I want to thank you all for joining us. I think this is like our third office hours within a month's time. Um, Sorry for so many in such a short time frame, but we've had a lot of things come up in that short window, and we want to make sure we get that information out to all y'all. So here we are. But wanted to go over some things with you guys that have come up in the last few weeks that Department of Health has put out policy-wise, and then also some redesignation follow-up that we had to touch on as well that came out of our redesignation. So that's why we're meeting today. So we'll get into it. As always, we're recording our office hours, so that'll be available for folks to reference moving forward on the website. I just want to confirm folks can hear me. Taking that as a yes.
Yes.
Okay, great. All right, good. And then you can see the slide deck if everybody can see that, if I can get a yes.
Yes.
Yes, we can.
Perfect. All right, great. And I can see the text chat has responses in there, so we're good there. And as always, if people got comments, questions, anything they want to talk about along the way, feel free to either use the chat function or ask along the way, and we can stop and talk through things. But with that, we'll get through into our agenda and we'll start our discussion. So we're going to touch on informed consent policy, our health home serving children CS transfer policy. We're going to get into billing for newly referred members for excluded setting, eligibility and appropriateness, and notice of decision and fair hearing. So those are going to be the topics today that we're going to touch on. And with that, Jessica, I'm going to turn it over to you for informed consent.
Hello, good afternoon. So we're going to run through the informed consent policy. This was added on to today's office hours because it was an annual review, and the timing worked out with the special office hours for us to be reviewing it. So we're just going to walk through the policy and then the various forms associated with this policy. So you can go to the next slide. So overall, when it comes to filling out consents, and this isn't necessarily always consent specific, but we want to make sure that any consent that we are reviewing with the medical consent or whoever is signing the document, that we're fully reviewing the form with them and they're fully aware of what they are consenting to and signing. We do allow the use of pre-filled consent forms, so you can pre-fill in some entities on there. However, if you're going to use a pre-filled form, we ask that the member initial next to each line. This is indicating that yes, that member is consenting to that provider. This is more specific on the 5055 than it is the 5201, because the 5201 we had that update to it, so it does look a little bit differently. And each line kind of is its own consented entity. So really you want to look at that 5055 when you're looking at a pre-filled consent form. We always want to make sure that our 5201 and our 5055 contain the CMA, the MCO, and the PCP. Those are three areas that we always look at to ensure that those are listed on the form. If there is a managed care company, if not, then it would just be fee for service. But if you list out all of the managed care companies, because we do see this from time to time, that on one line there will be multiple listed, you need to make sure that we know which one they are consenting to. So a circle, an initial, something like that. They must be completed and uploaded in their entirety. So you have to complete the entire form. You have to fill out every line. You have to check every box, and you have to upload the entire form. So if you do update, say page 3 of the 5055, you cannot just upload page 3. You have to upload the entire form each time it's updated. And we also want to make sure that we're listing AHI at the top as the health home, not the CMA. The CMA would go down the list of providers on the top left-hand corner. And on the first page, it's always going to be AHI. And then just something that we noticed as we did audits this year, we just noticed that the 5200 is still appearing in some members' records and the 5230. So the 5200 used to be a children's form associated with consent to enroll. That has been combined with the new 5201. So you do not need the 5200 anymore. That is no longer in use. The 5230, the language for consenting to have your information input into the UAS for CANS, for HCBS, that language is now included in your 5055 and your 5201. So we no longer need the 5230 in the form in the record any longer. You can go to the next slide. All right, so the 5055, that's, as we all know, is used for adults in self-consenting youth. So that is anybody who is over 18 or over, or if you're under 18, it's going to be pregnant, parenting, or married. And the 5201, that is our children's form, consent to enroll in information sharing, and that's going to be for anyone who is under 18 and not self-consenting. With the 5201, we have a frequently asked questions document that goes along with the 5201. So a couple of things that we're seeing, we absolutely need to make sure that we are reviewing that FAQ prior to that 5201 being completed. And there has to be documentation in the record that the FAQ was reviewed with the family prior to the consenter signing that 5201. When we are audited by Department of Health for our children's redesignation, they absolutely will be looking for that to be noted in the record. So I do recommend that that is noted in the enrollment note, intake note, your first meeting with the family. You want to make sure that there's language in the record that indicates that you have reviewed that FAQ form prior to completing the 5201. You can go to the next slide. So the 5201 also contains a section 2. That section must be completed with the member, part 1 if they're part A, I'm sorry, if they're 10 years old, and part B if they are 12 years old. There must be documentation in the record that indicates that the care manager attempted to meet alone with the member, so either 10 or 12, depending on what sections you're filling out, that you attempted to meet alone with the member and have those forms completed. If part A or part B are not completed, or if they do not have any of those providers, you must complete a tracking form. So if there are no providers, or it was denied to meet alone with the member is not developmentally appropriate to meet with them alone, they don't meet the age requirement, you have to complete that tracking form. And that tracking form needs to be updated either annually or at their birth date. So say you enrolled a 9-year-old and then they turn 10, you have to re-look at part A and then either complete it or complete the tracking form as they turn 12. Or at that annual mark, you want to make sure that you're reviewing that tracking form. You can go to the next slide. For the next consent form, we have our 5203. That's our educational release form. So that is to be completed for any youth that is enrolled in an educational setting. If the member happens to be in an out-of-district placement, so you're working with the home district and potentially where that member is actually attending their educational services, you have to have a separate consent for both entities. So this did come up during auditing. So we just want to point out that if your home district is, let's say, Glens Falls, you have a 5203 for Glens Falls, and then you also have a 5203 for, let's say, you're attending BOCES. You want to make sure that you have 2 separate consent forms on that. One thing that we did also see is if you do have a self-consenting member, so let's say you have a member who is 16 and they're parenting, they can sign the 5055 to enroll in health home but they cannot, if they are under the age of 18, consent on that 5203 for information or for the sharing of the educational records. That is a different law. So there are different requirements and laws that apply when it comes to educational information. You can put them on the 5055 so you can collaborate with the school. The barrier here would be access to those 504s and IEP forms. You can go to the next slide.
Jessica, you have a question. If consent forms are pre-filled and currently upload, do we need to have consents or go back and initial and re-upload?
Abra, I would update your consent forms if that is the case. I don't think you need to run out and update them all immediately, but as you have visits and in-person visits, I would work on getting those updated, because when we use a pre-filled consent form and they're not initialed next to every provider. So let's say, something that we see common is, we'll see, let's say you cover multiple counties. So your CMA covers Saratoga County and Warren County. What we'll see is Saratoga County DSS typed out and Warren County DSS typed out. If you do not initial next to each provider, essentially what that's showing me is that person has consented to both of those typed in DSS locations, when really that may not be the case. So we're really not looking at an informed consent in that instance. You want to make sure that those are updated as you do see your members. If Amy's question, do you have to initial next to each provider on the 5055 if it's not pre-filled? No, you only have to initial at the top. So if you're handwriting in, you only need to initial at the top unless you're updating it after the initial pass through. Okay, go to the next slide. So 5204, this is the withdrawal of the 5203. So when we disenroll one of our youth that's enrolled in an educational setting, we should make every attempt to have that 5204 completed. I understand that it's not always going to happen, especially if we have a disengagement. We have a question come in that says, this includes brackets. We use this method for clients who have difficulty writing. Kia, I'm not 100% sure what you mean by brackets. You can unmute yourself and ask that question or email us separately.
Yeah, so when you draw a bracket or draw I think I'm using the term the right way, to
Oh.
include all.
Okay, and then you just do one initial.
And I initial at the top and at the bottom of the bracket to include,
Yeah.
or sometimes top, middle, bottom, just to include like all the contents within this bracket.
Yeah, I think that's okay, especially
Okay.
if there is some sort of
TBI usually, or difficulty writing, any of the clients with difficulty writing.
Yeah, I would just note that either in the intake note or the note that's associated with you updating the 5055, just so the auditor is aware that there is a barrier and that you're just making it easier to complete the form for the member.
Okay, I will. Thank you.
Okay, so the 5235, this is our consent form. This is to cease information sharing and notify the member their right to the fair hearing. So this should be used in 2 instances: when you have an undocumented, uncommunicated discharge. So let's say like diligent search, or the member goes into jail and they're going to be in there for quite a while, or the member disagrees with their discharge. This is important because this ceases their information sharing consent. If you have a consented to communicated discharge, you do not need to issue the 5235. You can just issue the letter. We will review this further later in the deck when we review notice of decision policies. So those are our consent forms and our withdrawal of consent forms. Does anybody have any other questions on consent? All right, go to the next slide.
Thank you, Jessica.
Yeah, all right, we're moving into Health Home Serving Children CS transfer policy. So this policy is Only for our kiddos and our kiddos that are moving in and out of the HCBS process. So kiddos can transfer to Child and Youth Evaluation Services, or they can transfer from CS to Health Home. So CS is only going to serve youth that either do not have access to Medicaid and need access to Medicaid, or youth who have HCBS and do not want to be enrolled in Health Home. CS is not going to do any type of care coordination. That's only done by a Health Home care manager. So CS will take referrals for kiddos who do not have Medicaid, get them level of care approved, and either keep them or move them to Health Home if that member would like to receive Health Home care management services. If they stay with CS, they only receive access to services. There is no care coordination included whatsoever. And then we also have members that may be in Health Home that no longer wish to be enrolled in Health Home and would just like to keep their HCBS services. We can transfer those folks over to CS. Since April of 2019, I have never seen that type of transfer, but there will be a first at some point in time. So we will review that process a little bit. You can go to the next slide. All right, so the most popular and the one we see all the time is CS to Health Home. So whenever we get a transfer from CS, that means that they have received their level of care. They have an active level of care. They have active K codes. They would like to move into Health Home and receive HCBS services. So those transfers should always go through the Health Home. It should always be received by myself and Courtney for review. We will review the referral packet to ensure that we have all the required documentation before we send it to the provider. Sometimes I'll email you guys and be like, hey, we got this referral. This is the target population in this county. Do you have capacity to pick this kid up? But I am waiting on X, Y, and Z before we officially do the transfer. The problem with that and the reason that I hold on these transfers until I have all of the documentation is once we decide, you decide, AHI decides that we're going to accept that transfer, that member gets linked to you in MAP. The Health Home and the CMA, that care manager, that supervisor, we are all on the hook for all of that HCBS documentation to be in our record. And then we lose any leverage that we may have to collect those documents after the fact. So all of these should be going through the Health Home. I will double check everything. You will see communication with CS in your record. I will be documenting it in there on your behalf. The state is fully aware that this is our process that we use. Each Health Home does it a little bit differently. I've been burned one too many times by CS, so this is the way that we're going to continue to do that. The other thing we can do is we can transfer to CS. So if we do have a member that is in Health Home and they're receiving HCBS, they no longer want care coordination, but they just want access to their HCBS services, we can transfer that person back to CS. We do have to remember with them transferring to us or to CS, we always have to educate that member on the difference between the two entities. So we'll always be looking for that note that you have educated the member on the differences between CS and Health Home. If we're working with a member that's no longer Medicaid eligible, but we think that they would be eligible for Medicaid and the HCBS waiver, we can transfer that member to CS. So that would be if that member is not going to receive community eligibility for Medicaid. So let's say the income is too high and that's why they lost Medicaid eligibility. That's when you would send them over to CS. If it's just a lapse in Medicaid, you would just help that family recertify. And then we have to complete the CS transfer form that we sent over to CS. Does anybody have any questions on this policy? All right, moving on.
Thanks, Jess.
Okay, so the next policy that we're going to be looking at is billing for newly referred members from an excluded setting. This is not something that we see too terribly often, but there may be instances where we do see this. So if we have a member who is being referred to health home from an excluded setting, we can enroll them and bill for them 30 days prior to discharge if they have active Medicaid. The reason I'm saying that because most of the time we got these referrals, they usually go to the health home where I see them come through SPOA and they don't have active Medicaid because they're currently incarcerated. We cannot enroll those folks and we cannot bill for them because their Medicaid is not active until discharge. So we always want to make sure that we're verifying that. And that also, if we're doing it during that 30 days, those core services, they cannot duplicate routine discharge planning by the facility. So you want to make sure that you're not duplicating anything in that last 30 days. You can go to the next slide. If we are receiving a referral for a member that's in an excluded setting and they appear to meet HCBS eligibility, then in that 30 days, the health home care manager can start gathering that documentation. The facility potentially can even give you some of that documentation, complete that LPHA form, and then you want to make sure that you're doing that LOC within 30 days of enrollment. And then anytime if we do get a referral and that member does not have Medicaid, typically the buck stops there for us. We really don't proceed with the next step, but they should be referred to CS. So if we do get a referral from an excluded setting, they don't have active Medicaid, the referrer should be checking that and know what to do. But if they don't, you can say back to them, you can refer to CS. If it comes through the health home, that is what we do. So once the referral has been accepted by the CMA, the assigned care manager will reach out, the intake will occur, and then the enrollment segment will happen. If for whatever reason you do complete an enrollment and that member is still in that excluded setting and has not been discharged yet, and you're going to bill, and then as we all know, discharge plans change, something may occur, and that member is going to stay in that status, what you would do is you would append the member just like you would if that was any other enrolled member that went into an exclude setting. Does anybody have any questions on that? All right, I'm going to punt it over to Taylor, who is going to take the next couple of slides for me.
Thank you, Jess.
Thanks for the punt. Okay, I'm briefly going to touch on the eligibility and appropriateness policy as it pertains to the CES tool. I just want to preface this update with there has been no updates to the actual policy, but this is just based on feedback we received from our redesignation audit. The big thing that they really hounded us for was having those CES tools and then the appropriate CES actions after the initial CES tools, so follow-up CES tools or disenrollments, they need to be done to the day. That was a big thing, a big takeaway from our redesignation results. So just to briefly go over the CES tool, it must be completed for all enrolled adult members with the exception of those Health Home Plus members or those in the Health Home Plus step down. What it's doing is that it's evaluating that the member is still eligible and appropriate for the health home service level, and the CES tool must be signed and finalized by a supervisor. Next slide. So just as a reminder, for non-Health Home Plus members, the initial CES tool is due 365 days from the date of enrollment in Health Home or their consent date. If the member is Health Home Plus, you guys do not need to complete the CES tool, but please, please, please make sure that your sub-programs are entered. When I'm sending out those CES tool reports or putting them in the quality notebook, I'm filtering out anybody that has a Health Home Plus program or a Health Home Plus step-down program. So if you have folks that are in one of those two populations and they don't have that program in there, you're going to get that member is, you know, overdue or what have you for their CES tool, but really they don't need it done. So be mindful and stay on top of those sub-programs for those specialty populations. If the member is in Health Home Plus step down, the due date for the tool is 12 months to the date after the step down period has ended. And then again, please use the reports and data then to support the timely completion of the assessments. If they're not done correctly or on time, it will result in a billing block. Next slide. So just the different outcomes that you can receive for the CESS tool. For continued enrollment, please ensure that you are updating the plan of care if needed so that the members' needs are represented in the plan of care as you represented them on the CESS tool. And then ensure that you're doing a follow-up tool every 6 months to the date moving forward. For a disenrollment outcome, the member must be discharged within 60 days. Everything during that 60 days is billable, but any service delivered after that 60 days has been completed is not billable. And you will complete the disenrollment process per policy for those members that are getting disenrolled due to the CESS tool. And then the third outcome is more information needed. We don't have a ton of these, but if you do happen to get this as an outcome, you have to do the follow-up tool within the next 60 days. The CMA must comply with whatever the outcome of the second tool is, and a second outcome of more information needed is not allowable.
Taylor, you had a question come up in the chat. In data den, what do the highlights mean? I had a few billings get kicked back because we thought the tests were not to be done due to this DSC status within the past year, what we thought the highlights meant.
Yes, so the highlights do mean that they have been pended. We did have a little bit of a wonky issue with that for a while. So if anybody has any questions at all on if you're wondering if it's due or not due, please feel free to shoot me an email. Or if you think it's working incorrectly, please feel free to shoot me an email and I can take another look at it. It should all be resolved at this point. But please feel free to email me and I can double check with what's in NetSmart and then also what's feeding to MAP to just make sure that we're matching everything appropriately and making sure that the billing is going through. I know Courtney has experienced some kind of wonkiness with rejections from MAP just based on the logic that they have built in, and it's nothing that any of you guys have done on your end. It's stuff that we're still investigating and going back and forth communication with MAP. So again, if you have anything that you have questions on, please feel free to reach out. And if we can't figure it out, we will bring it to MAP. Thanks, Ariel. Next slide, Travis. Okay, so just some examples. So if the member enrolled on 12/1 of 23 and they were non-Health Home Plus, the initial CESS tool would be due on 11/30 of 24. The member outcome when you did that CESS tool was continued service. So then the Health Home Care Manager would review the plan of care to ensure that it's reflective of the member's needs. The 6-month follow-up tool for that member would be due on 5/29 of 25. And the member received an outcome of more information needed. They then had 60 days to redo that tool. So they would have until 7/28 of 25 to complete the follow-up tool. And if they don't get it done by that point, the member is non-billable. The follow-up tool must be completed, and then the member outcome was disenrollment. So the member must be discharged by 9/8 of 25. The member is in disagreement with the results. The Health Home Care Manager will complete the discharge process, including issuing the 5235 and reviewing the fair hearing process with the member and informing them of their rights. And with that, I think I can punt it over to Jessica to kind of dive into that fair hearing process and the notice of determination, unless anybody has any questions pertaining specifically to the CESS tool.
Great. Thank you, Taylor.
All right, so now we're going to jump into notice of decision and fair hearing. This policy was just updated by the Department of Health and was really the driver for our special office hours because it was effective 12/1. So new notice of decision forms have been added to the DOH website and they should be used starting immediately. I've linked them here. When Travis sends out the slide deck, he's also going to send those updated forms so everyone can start using them. You can go to the next slide. All right, so we're just going to walk through a couple of forms that we're issuing to our members, and all of the forms that we're issuing to our members that we're reviewing right now do give that member the right to a fair hearing. So the first form is our 5236, and that's the notice of denial in enrollment in health home. So that is when someone has a referral sent to us and we deny their enrollment into health home. So we are saying they do not meet eligibility and appropriateness criteria. They have an incompatible RE code. They don't have active Medicaid, whatever the reason may be, and we're denying them enrollment into health home. We would issue the 5236, upload it into the chart, and then we must issue this form to the member within 5 business days of the determination. So if you check ePaces and there's no active Medicaid, the date that you checked ePaces and determined that they didn't have active Medicaid, then you would issue that within 5 days of that date of determination. The next form we have is our 5234, and that's our notice of enrollment. We shouldn't have anybody disagreeing with our notice of enrollment unless you're an AOT member, because the program is voluntary and you don't have to be here if you don't want to. So you're going to provide the notice to the member, also upload it into the record, and it must be issued within 5 calendar days of enrollment. So that's the same process that you guys do now. And go to the next slide. So as promised, we're going to touch again on that 5235, the notice of disenrollment for health home. So this form is issued to a disenrolling member who is in disagreement with the discharge, or the care manager has not had a documented conversation about the discharge. So this could be somebody who, let's say they're an adult and they're disenrolling due to the CES tool. They are adamantly disagreeing with their discharge. Let's say that they're a family of 1 youth that is enrolled in HCBS waiver. They come out that they're ineligible. Their LOC is ineligible, so they have to be disenrolled from health home because they're family of 1. They're adamant about that disenrollment. You would issue the 5235. Or you have somebody who has pended for an excluded setting. You can't have a documented conversation with them, incarceration, maybe they're hospitalized, or who has gone diligent search and there is no documented conversation about discharge. You would issue the 5235. This form must be issued 10 days prior to the disenrollment date, and that's based on date mailed. So if you're at the office and you're filling out your 5235s and you put today's date 12/9, but you know that your mail, you don't put it directly into the mailbox and it's going to, sit there for a few days before it's picked up. You want to give yourself a couple of extra days, because OTDA, if they get a fair hearing, they are going by the postmark date. So it is 10 days, but you might want to give yourself a couple of days of cushion depending on how each CMA is mailing out these documents. This is an update to this policy. Before it was just 10 days. Now they're going based on the postmark date. I believe this is happening because enough people went for a fair hearing. They were displeased with the results. They're automatically being overturned if that member didn't receive 10 days notice. And it's 10 days in general, not 10 business days, Michaela. Yes, thank you for that. You're going to see it differ though. This is 10 days to get that notice out based on postmark date. So not all members do need that 5235. If they agree with their discharge and you have a documented conversation with them, they only receive that discharge letter and they do not have a right to file a fair hearing. So if a member graduates and then a week later decides that they don't want to graduate, but they've already been discharged from health home, they do not have a right to a fair hearing because they agreed to their discharge. So you're not always going to have to issue this notice. You can go to the next slide. So we also have the 5287, which is the notice of enrollment or denial into enrollment to HCBS. So this is for our kiddos that are going for the HCBS waiver. So they're attempting to go through that process and get a level of care. So this is issued to any member who is enrolled in HCBS or denied enrollment into HCBS. And this has to be issued within 5 business days of the date of determination. Michaela, while I said they don't do this consistently, because here they say 5 business days. So 5235 is 10 general days. 5287 is 5 business days. This has not changed. So anybody who's currently serving those HCBS waiver youth, this 5 business day has stayed the same. So if you're denied enrollment into HCBS because you don't meet level of care, or if you do meet level of care, either way, you are getting issued this notice of determination. Your notice of determination is only good for 365 days because, as you all know, you need a level of care every 365 days. So you will be recompleting this form. If you go to do a level of care and you are ineligible, or for whatever other reason you are disenrolling from the HCBS waiver, you're going to issue the 5288 notice of disenrollment from HCBS. So this is issued to any member, every member who is enrolled in waiver who is disenrolling must be issued the 5288, and it has to be issued within 5 business days from the date of determination. So that's the date that the medical consenter says, I no longer want my youth to be enrolled in HCBS, or it's the date that you get the ineligible level of care determination. That's the date of determination. Within 5 business days, you have to issue this form. You have to issue the form, but then you have to give the family 10 days notice, again, based on the date mailed, so that postmark date, before you can actually take them out of HCBS and disenroll them from HCBS. They have to receive that 10 days notice before you take any action. Does anybody have any questions on the notices before we get into the fair hearing process? The major change here is now we're looking at that postmark date. Otherwise, everything has relatively stayed the same. You're going to get those new forms. Those new forms only really have, the forms are relatively the same with added language to the 5236, 5235, 5234 for CES and HCBS language. Otherwise, the form has relatively stayed the same. All right. You can go to the next slide. Okay, so now we're going to move into the fair hearing process. So all of the above forms that we just reviewed, when issued, give the right to the member to file a fair hearing should they be in disagreement with the decision made. So all members have 60 days from the date that they receive the form to file a fair hearing with OTDA. So with that, as soon as you are made aware, so if you go to, you have a, let's say, discharge meeting, and you're fully aware that that member is going to file a fair hearing, you should be notifying the health home as soon as you are made aware of that. So we can keep track of people that we're expecting a fair hearing notice on. So AHI, so right now the process is that we compile the evidence packet for the hearing, and we attend the hearing, whatever modality that that member has requested. So they can request a telephonic hearing, they can request a an in-person fair hearing meeting. Right now, AHI is compiling the evidence packet, and we are attending those hearings. There may come a time, the language is loose in state policy based on whether it is left up to the health home to determine who would be the best representative of that fair hearing. So there may be instances where a CMA representative is required to be there. Right now, I have represented the collective at the fair hearings, but there may be a time that that does change. Anybody who has had a fair hearing go through, we meet with you, we discuss, you know, what the case, making sure that I'm fully prepared to say whatever I need to at the fair hearing and make sure I have everything compiled for the evidence packet. So you really, really want to make sure that everything in that member's record is uploaded. You have all of the supporting documentation to support that discharge and whatever that decision may be. Aid continuing. So when they are filling out the backside of their notices for notice of decision, when they fill out their fair hearing, they can click a box that's for aid continuing. So they can check a box that says aid to continue. This will allow that member to continue to receive care management services or care management and HCBS services until a determination is made by a judge. So if that is checked, we have to continue to serve that member. Now, that member may be disgruntled and no longer wants to work with you specifically, but still wants to receive services. The health home will ensure that that member is transferred to another CMA, another care manager, to continue to receive those services. So again, it's super important that we are made aware as soon as possible if a member is going to file a fair hearing and select aid to continue. What happens is that gets sent into OTDA. OTDA sends a form to the Department of Health. The Department of Health sends a form to us. This is taking a long time. By the time all of this happens, typically what has happened is that member has already been discharged out of our system. What we should really be doing is holding off on the discharge for anyone who has aid to continue and not discharging them, so their segment remains open. There will be another modification to this policy later this month when DOH releases it. What that is going to do is it's going to allow for functionality in MAP, and you may see changes in NetSmart that will allow you to, when you go in to do a contact note, you can pen them for DSE, you can pen them for excluded setting. You now will be able to pen them for aid to continue, so it holds their segment. So if you have a non-compliant member that doesn't want to do their care plan, they don't meet eligibility, so you don't have anything in place to bill, when you put that pen segment in for them, you are no longer held to those billing block standards. So that is what that will allow you to do. But MAP is not there yet. It's going to be in the next MAP release. NetSmart has to put that functionality. We were talking with them at our last meeting. We will see an update from DOH and policy. We will then put that out to the network. Then we will issue guidance on how to use that functionality. But we need to be made aware as soon as possible that that member is filing a fair hearing and they have requested aid to continue. Does anybody
Yes.
have any questions on that?
Jessica, I just wanted to
Yes.
stress that this needs to come from the member. The member should be completing this documentation to file the fair hearing, the aid to continue. It's not the health home filing it. It's not the CMA filing it. It's something the member needs to take the initiative to do.
Yes, that is correct. The responsibility of the health home care manager and the health home care manager supervisor is to ensure that members are aware of their rights. So you need to make sure that they know that their right to the fair hearing, they know their right to aid continuing, because when you're discharging a member and you're having a discharge, you have communicated that with them. If you're just mailing them the paperwork, because let's say that they're disengaged, you kind of cannot have that conversation with them. But yes, the member needs to complete the form. It needs to have member signature on it. If you are aware, however, that this is occurring, you need to notify the health home as soon as possible. You can go to the next slide. All right, last slide, and then I'm done. So right to conference. So our members also have a right to conference with the health home. They can do this in lieu of a fair hearing or concurrently with a fair hearing. So if a member is being discharged and they would like a right to conference with the health home, they can give us a call and they can request a conference. It's like a mini fair hearing. We meet with the member, we meet with the CMA, we review the record. We will either uphold the determination of the CMA or we can overturn the determination of the CMA. We will then issue a letter within 10 days of that conference. We will issue a determination to the member. So we will say we uphold so-and-so's decision of discharge, or we have overturned their decision of discharge. Here are next steps. That could be going back to that CMA. It could be going to another CMA. We have never had a formal right to conference, so this is an option for our members. I don't know if it's always being explained to our members. We certainly get our fair share of complaints and grievances, but no one has ever asked for a formal right to conference. So they can do this in lieu of a fair hearing, or they can do this in conjunction with a fair hearing. So decision after fair hearing. So once that fair hearing occurs, they can be in the favor of the member or not in favor of the member. And either way, we must comply with that decision. So if it is in favor of the member, then we either unpend the member because they were pended because they had aid to continue, we continue working with them. We re-enroll that member. Or if they had aid to continue and it's not in favor of the member, we will then discharge that member. But no matter what the outcome is from that fair hearing, we must comply with it. We can also request for reconsideration of that determination. So we can say we disagree with the determination that was made by the judge. However, while that's being re-reviewed, we have to comply with that determination that was originally made. Same thing if someone clicks aid to continue and we are then binding to continue to serve this member, we can send in a refute to OTDA and say, we don't think this person should have aid to continue. Here is why. And then they will make a determination as to throw that out or continue to serve the member. Full disclosure, this has only happened once and it's never gone in our favor. So just throw that out there. So these are our big changes to the notice of decision, just really making sure that the care manager and the supervisors are really ensuring that we are following this process and that our members are being educated on their rights as members. Should this info be added to an outreach letter to show proof of making members aware? So that's a question from Tanya. You can absolutely update your intake letters, your outreach letters to kind of show this. The process is also semi-discussed in the members' rights and responsibilities and complaints form. So if you look at our complaint policy, we do have the complaints, rights, and responsibilities of the member sample in that policy. This is somewhat discussed in that process. Right now, no one is auditing us to show that these conversations have occurred, but our big thing is just making sure that these forms are completed correctly and uploaded in a timely manner. That's the most important thing, because we often see that these forms are being done incorrectly and at the wrong time cadence, if that makes sense.
I would dare say, given the implementation of the CES tool and given the robust changes to this policy that's being rolled out right now by the state, that this will be looked at and probably audited moving forward for health homes across the state. That would be my thought. This process will be looked at closely as health homes are audited moving forward.
Yes, right now, for anybody who serves HCBS youth, you know that I audit for and the state audits to make sure that you are issuing the 5288 and the 5287 in a timely manner, the date that it's issued, the notice date. They do look at redesignation for adults. They did look at our 5235s. They did look at the notice date. So you always want to make sure that your dates are all correct and then they're being uploaded in a timely manner. And that the disenrollment, if they are being disenrolled, is not happening before that 10 days. That's an automatic overturn of a fair hearing. If you issue the form and then in under 10 days, you turn around and discharge the member, fair hearing will automatically be overturned. They won't even listen to anything. They don't even want the evidence packet. I believe it's probably a time-saving tool. As Travis said, there's been a huge uptick in fair hearings. We've had one person for 14 months on aid to continue with a fair hearing because there's no date. Any other questions on notice of decision? Again, you're going to see a second iteration of this policy come out 1/1, because that will formalize those map updates and that pend function in NetSmart once all of that functionality is ironed out between map and NetSmart. All right. That's all I had for today.
Nothing like a boatload of policy before the holidays, right?
This is what we get for trying to do away with office hours in December.
Right. Well, thank you, Jessica. Thank you, Taylor. Did anybody have anything that they wanted to talk about why they got us? Thank you for your time today. I hope you all have a good rest of your day, and thank you as always for everything that you do. And I hope you all have a great holiday season. Take care,
Bye.
everybody.